Our EP session, and we'll start with our friend Dr. Mohammad Hajjiri. He's one of the best electrophysiologists in the area, and he will be talking about PVCs, VT, burn them all, or burn the hell out of them. Okay.
Or whether to burn them all.
Burn the crap out of them. Okay, thank you very much. Thank you all. Thank you for the kind invitation. And let's talk about PVCs and VTs. Let's talk about some real cases. This lady, 72-year-old lady, who presented a long-standing history of sustained VT. She has status post-ICD implantation in 2020. And this lady was very interesting. So she's very unlucky in terms of she has metastatic cancer. She has she also had kidney injury, and then on one day she presented with incessant VT that we ended up taking her to the lab and then ablating her, which means you put a catheter and then you look for the area inside the ventricle that is where all the electricity is coming from, and then you end up burning it. So for the sake of time, because I only have 14 minutes, so I'm going to be a little quick with this. This is another gentleman who has long history of VT. He had an unsuccessful attempt of a conventional VT ablation in 2017, which was complicated by myocardial perforation. And just for the non-EP, I know like you guys see these colors and all of that stuff. This is the aorta. Here are the cusps in here, and then here is somewhere here would be the left main. The proximity of the original AED was a bit challenging, but despite all that, we managed to burn this area without compromising the left main. Okay, this is a video, if you can, just to give you an idea of what we do. Can we play the video? The video. It should be a video. Oh. Okay, so I guess the video is not going to work. So what we do is that we basically construct a three-dimensional map of the left ventricle, and then you'll see colors. Unfortunately, the video is not working. The colors are, this is not the same patient. The colors show, red color would be diseased area, and then anything that is purple would be the normal. So you basically target the red and the rainbow colors. Like this is another patient who's 50 who also presented with VT, and this is just to kind of this guy presented with fascicular VT, where you don't really need the defibrillator, but and this is a small diagram where we actually see where in the ventricle this is. So in this patient, the purple is normal tissue, and this is where we ended up burning. This is the left ventricle. This is here the aorta, and then somewhere here, close to the septum, we had to burn this whole area in order to terminate the ventricular tachycardia. Okay, so my talk is about VT and PVCs, and sometimes we just use them loosely in between. If you have a structurally normal heart, and you have idiopathic LVVT, you can do catheter ablation, or you can do medical therapy. When the ICD is not indicated is in outflow tract VTs like RVOT or LVOT. The outflow tract VTs and in fascicular VTs, you don't really put an ICD in these patients. You can carry on here if you have a high PVC. I think if there's one point to tell, if any patient you have who has a PVC, you need to count how many PVCs you have. If you have more than 10,000 PVCs in the 24 hours, it's okay to go directly to catheter ablation, and it's okay to go, if it's more than 10,000, it's okay to go directly to the catheter ablation. Alternatively, you can also say medical therapy. ICD is also not indicated unless there is sustained VT. Now, if you do have LV dysfunction and you do have multiple PVCs, then you have to go for catheter ablation. The reason for it is because when you have high burden of PVCs, when you ablate the PVCs, then the ejection fraction gets better. You can also use antiarrhythmics. When you have low ejection fraction, you cannot use flecainide. So one of the things you can use is sotalol. I don't really like amiodarone. I'm sure you guys know about this. Other than that, if you also have a PVC trigger that is causing polymorphic VT, you can always go after the PVC trigger. Okay, so you have somebody who comes in with high burden of PVCs. PVCs, you do a Holter and then you find that they have 15,000 PVCs. So the first thing you want to do, you want to make sure that, of course, you want to take the patient clinically, but at the same time, you want to make sure that you've done an ischemic workup. Sometimes ischemia can be the driver of PVCs. The other thing is ETTs, cardiac MRIs, and antiarrhythmic drugs that can also take some considerations. So ETT is, in a way, I use, which ETT is the exercise treadmill test, and I use the exercise treadmill test to see if these PVCs get better or they get worse. At peak exercise, if the PVCs disappear, that's usually a better sign, and you're, in a way, you can rule out some of the myopathies where these PVCs actually get worse with exercise. Things like CPVT, you can have an increase in those PVC burden at peak exercise, and sometimes you can have a bidirectional PVC. This is another patient where this is the very common, unfortunately the videos I guess are not working. This patient had an ICD in 1995 due to history of cardiac arrest. She had a PVC burden of 26%. We've trialed mexiletine, that did not work. We've trialed sotalol, that also did not work. And we had the 3D assisted ablation, and it was very simple. It was a very simple right ventricular outflow tract VT that it was ablated within like 15 minutes. The focus was gone in the right ventricular outflow tract. Now, does right ventricular outflow tract PVC or VT cause sudden cardiac death? Not really. But the history, since it's in 1995 and she had the ICD implanted at the Mayo Clinic, it's still unclear. And the past 30 days, she's never had a shock. So I would say this was a bit questionable. However, the PVC here were easily ablated. These are sometimes these are some of the couplets that we see. Some of the PVCs that we see in this patient, there's a run of a fib, and there's like some PVC here. This is another patient with a very high burden of PVC of 40%. There's non-ischemic myopathy, significant family history of ischemic cardiomyopathy, and then also underwent successful PVC 3D assisted PVC ablation, and it goes away completely. A Holter monitor following the ablation showed less than 1% PVCs. You can always still have some PVCs, but the whole idea is try to reduce the PVC burden to less than 10%. Some studies that are important, which is the beneficial effects of catheter ablation of frequent premature ventricular complexes. Here they show that ablation of frequent PVCs improves the cardiac function, especially in patients with LV dysfunction. So when you have somebody who has ejection fraction has dropped from those PVCs, just burn them, ablate them. Ablation is it's a safe catheter-based procedure. It is safe, it has a low propensity for complications, and it has really good outcomes in most of the time. All right, so now let's talk about, I wanted to put the slide specifically just because in our area we use a lot of amiodarone, and this is a very, it's just a kind reminder how amiodarone is such a terrible and destructive medication when it comes to health. So when would we use amiodarone? It's really up to the practitioner. However, it's not a first-line treatment. The European Society of Cardiology showed that initial treatment with amiodarone carries a 15%, And then after 1 year, it can be up to 50% from after prolonged administration. And then let's remember some of those adverse effects. Bradycardia, prolonged QT, sometimes hepatic dysfunction, 15%. Thyroid, hyperthyroidism, 3%, and hypothyroid, 20%. Pulmonary, less than 3%. But if you have pulmonary fibrosis from the amiodarone, this is destructive. This is a horrible, it is potentially fatal for something that's very simple as a PVC that could be ablated and patients can do much better. Dermatologic, neurologic, corneal deposits and optic neuritis less than 1%. So we see corneal deposits, but they don't really affect the vision much. However, so amiodarone is not something we want to use all the time. Beta blockers, of course, are the mainstay of treatment initially, but do not hesitate to think about more definitive treatments of patients with PVC and VTs, more definitive therapy than using amiodarone and or beta blockers. It's exactly like making a pact with the devil. They always want something in return. It's a medication that can be beneficial, but will result in some high incidence of severe and irreversible side effects in return. 3D assisted ablation is the way to go in many, many cases. Now, I don't want you to think that I'm just encouraging 3D assisted ablation without medical therapy. Beta blockers are a good treatment. We can always start with beta blockers and then repeat the Holter and see if there's any effect. However, if there's no effect, there's no point, in my opinion, to constantly keep changing the beta blockers from carvedilol to bisoprolol to, it's not going to make much of a difference. Thank you very much for the interest of time. And let me know if you have any questions.
Thank you, Dr. Mohammed. Any question for Dr. Mohammed? Ayman.
The side effect of amiodarone really when the dose is 400 milligram and above. But I know we're probably using a lot of amiodarone because of lack of other choices. But most of us use probably 200 a day, and sometimes we drop it to 100. Do you have any peripheral beta blocker, be it selective or non-selective, when you treat these patients?
I mean, for amio, you can drop the side effects by dropping the dose to 100 milligrams, but 100 milligrams, I'm not so sure, would be as effective as the regular dose. For amiodarone, you need to load with 10 grams, and then after the 10 grams, you have the steady state concentration in the body. So once you have the steady state concentration, so it doesn't really matter what dosage you would have to maintain this steady state concentration. Eventually, once you have enough ammo in your body, then you're going to have some side effects. But dropping the ammo to 100 milligrams is going to drop the side effects, but at the same time, it's not going to be as effective.
Further.
Raed Al-Jitan from America. Mohammed, we're confused about this 10,000, 20,000, and I don't see any literature to support your data that if it is this much, you have to wait, this much, you have to intervene with ablation. And non-sustained, sustained.
So
I need clear data and literature support you that if it is more than 10,000, more than 20,000.
Yes, there is.
What is sustained? When is sustained when you intervene in a structurally normal heart, to be clear? Thank you very much.
Correct, yes, it is. There is literature, and the studies show around 10,000 is when the PVCs will start causing a decrease in the ejection fraction. Initially, when I was tested for the boards, it was the magic number, as I guess American boards, they do like the magic numbers is 24% PVC. At more than 24% PVC burden, it is supported by studies. You will have a much higher propensity for heart failure.
Excuse me, say 24%? That's more than 10,000.
the 24%, you have an average of 100,000 beats in one day. So 24% is around 24,000 PVCs a day. So if you do have it, and a lot of our patients, they come to us with 40%, 30. So if you're always in bigeminy, then when you think about it, it's around 50% PVCs. Now these PVCs, when they go higher than 24%, then you are at risk of LV dysfunction. Now the 24% number was adjusted recently for 10% because which is an average of 10,000 PVCs, which is kind of a magic number where we need to intervene and treat.
Is it of importance that it coming in the duplex or triplet more than the number?
I'm sorry, what was your question again?
I mean, if the extrasystole or PVC coming in duplet or triplet, more important than the number of the beats per day?
Well, I mean, if you have triplet, that means you have non-sustained VT. My always concern is that if you have more than 30 seconds of VT, of non-sustained VT, this is basically the definition of sustained VT. So this is actually dangerous. If your PVC morphology is that of left ventricular or right ventricular outflow tract, then usually these patients do not have sudden cardiac death. If you have fascicular VT, then these patients do not have sudden cardiac death, even if they have VT and sustained VT. So usually you ablate them and then the problem is solved. But if anything other than that, like if they have history of ischemia, then this is associated with sudden cardiac death and they do need a defibrillator. Hope that answered the question.
Dr. Mohammad.
Yeah.
Thank you very much. According to guideline, I think before 1 year I told you when you were sitting there about this statement. According to guideline, treatment of choice for arrhythmia presumed to be ischemic in origin, cabbage class 1A, PCI class 1C. This is one. And if we are facing a case of resistant VT to all modality of treatment,
yes,
we are left with cardiac transplant.
I don't know how feasible it is to cardiac transplant. So in incessant VT in patients with advanced heart failure, and especially in patients who, and I think you're talking about the literature with patients with LVADs and who've had incessant VTs, but generally patients who've had ischemic VT and it's incessant VT, you need to ablate that VT, and if it fails the ablation of the VT, you need to look for an epicardial focus, which I think Dr. Kaabi is going to talk about epicardial, and if that fails, then I guess you might be, that's where might be heading. If it's a burnt out ventricle and it's not working, then that might be the route that we're heading.
Okay. Dr. Sukaina.
Thanks, Dr. Mohammed. My question is, when to send our patients for ablation? Is it just the burden or the symptoms and quality of life? I mean...
I'm sorry, can you repeat the question? I didn't hear.
When to send our patients for the ablation? Okay. Is it just the burden or quality of life and symptoms? Many times we do the whole 10 and the count is less than 10%, and still the patients, they have a very, very bad quality of life. Can we just reassure them that it's okay, or...
If you have, let me tell you a personal experience. I had PVCs myself 7 years ago, and that week when I had that PVCs was the worst week of my whole life. It was horrible. I could feel every single PVC. I couldn't talk. I couldn't give a lecture. I was in an academic center at that time. I was an academic cardiologist in the U.S. in Cleveland at Case Western, and a week later, I decided for the ablation, although my burden was very low, it was about 3%, and on the table, it just disappeared on their own. So if the lifestyle is really bad, then you just go after them and try to get rid of them. If you give beta blockers and the male patient develops sexual dysfunction, then you need to get rid of them and try to ablate them, even though that the burden is low. It's very challenging in the EP lab to ablate a very low burden PVC. That's why we don't like it. However, we can always give isoproterenol. I can give adrenaline. We can try to induce these PVCs. Sometimes they are induced by bradycardia, phenylephrine. epinephrine can sometimes be used in order to kind of invoke them, but if the lifestyle is bad, even though the burden is low, then we should get rid of them.
So we can safely reassure our patients, talking about the counseling. Many patients, they are afraid of it.
Yes.
Can we, regarding the burden is low, can we safely reassure our patients
Correct.
that it's
So
safe
remember,
not to do that?
if you have, let's say, a patient who has a burden of 5%, and you don't know what to say to tell this patient, remember, ischemic workup is important. Cardiac MRI, especially in the day and age of COVID, because there's acute myocarditis, and sometimes this carries on for a whole year after COVID, where this myocarditis is causing those PVCs. Cardiac MRI is very helpful. ETT is very helpful. Run them on the treadmill if they can. Now, if the ETT, the PVCs disappear at peak exercise, if the cardiac MRI is normal with no infiltrative myopathies, and you can just reassure them and then repeat the Holter in a few months, like 3 months, and see if that burden increases, stays the same, or it drops. Sometimes it's caused by a localized inflammation and it goes away on its own.
Thanks.
Okay, so Mohammed, you do cardiac MRI with non-ischemic VTs.
Correct.
And when you go to coronary cusp VT, do you check the coronaries while you are ablating?
We do sometimes, yes. If you are very close, we do. We always check the coronaries if it's an epicardial focus to make sure that you're not burning the artery. For the case that I presented, which was a former minister, it was on top of the cusp, which was right next to the left main, but I didn't really, we could tell where it was, and this is where TEE or ICE would be very helpful, because you know exactly where you are, and you know exactly that you are far away from where the focus, from the left main is. So I usually do mine, not always, but TEE guided, where we can see where we are burning.
Okay, and
دكتور حجيري بدي أسألك يعني we in Jordan we don't have a lot of options for antiarrhythmic, so
we have no options.
Over the years we are using cortisone like rice and sugar.
Yes.
And yet the commonest side effect I see is the thyroid. That's the major thing. And if the patient develops thyrotoxicosis, we used to treat it and continue cortisone. If he develops hypothyroid, we used to treat it and continue cortisone. But we did not see the pulmonary fibrosis a lot, the eye deposits, not too much. I don't know.
So I think one of the very important things is I think there are lack of studies, really, because if you do study these people and do PFTs, one of the things that we don't do in Jordan is annual PFTs in patients with amio. So we do use amio back in the States. I used amio every now and then for my elderly patients. I do have in Jordan some of my patients on chronic amio. I have an 85-year-old with VTs. I've kept him on amio. But one of the things you want to follow is PFTs, annual PFTs. Make sure that they're not developing lung fibrosis, corneal deposits, all of that. Now, if we don't have, I don't know that there are enough studies. I think this is something to follow up. But I can give you an anecdote. I know anecdotes are not sufficient, but anecdotally, I have seen a couple of patients of mine who were on amiodarone for AFib for 8 years. The patient was still in persistent AFib. And so the amiodarone wasn't really doing anything, and then she was very, very short of breath. She was cathed several times, and several of her arteries, smaller arteries, were thought to be responsible for her dyspnea on exertion. I'm not so sure that may have been the case. So I think that there are some underdiagnosed, because, you know, if our population isn't much different from the world population, maybe a little bit different. So if we have prevalence of these medications and these studies that were done elsewhere, telling us that there's this percentage on European population causing all these issues, it just means that we're not looking for them enough in Jordan.
Actually, Mohammed, lung fibrosis is not very common, but when it happens, it's really serious.
Yes.
Serious.
So lung fibrosis is less than 3%, but when it happens,
it's bad. It's really bad.
It's absolutely horrible. And that's, of course, again, calling for, we need antiarrhythmics in Jordan. I do not know why we don't have antiarrhythmics in Jordan. We only have cortisone.
And we have some companies, drug companies, that make antiarrhythmic drugs.
And
they set it outside.
Correct. They export them to different countries.
Dr. Mohammed, any idea of half-life of cortisone?
The half-life is about 45 days.
60 days.
It's 1 to 2 months.
500 hours.
Okay, that's a lot. Yes, Dr. Yahya.
Thank you very much, Muhammad. But I am watching a kind of increase interest in, as you mentioned, symptomatic PVCs ablation. And it seems to me, if you're aggressive enough, it becomes the first on the algorithm. Is there any concern that ablation long-term might induce, with the scarring, more serious arrhythmia than those just
Absolutely. If you don't do it correctly, there's a very, very important question is that if you, so this is how I always explain it to my patients, is that dead cells, they will not hurt you, they're dead. Alive cells, they conduct electricity and they're perfect, but it's those zombie cells. So if the cell is half dead and half alive, then it conducts the electricity in a slow fashion and then it's going to start causing chaos. So if you're going to ablate, do it properly and kill those, don't let them, make sure you don't leave any of those zombie cells that will be a focus for future VTs and cause more problems.
Thank you, Mohammed. I think we have to move forward.
It's my pleasure now.
All right, thank you very much.
Thank you. It's my pleasure now to introduce Dr. Salem AlKaabi, our guest from United Arab Emirates. He's interventional electrophysiologist at Zayed Medical Center, and his main interests are in Brugada, of which he's been talking to us, and epicardial ablation.
Assalamu alaikum. Thank you for organizing committee for inviting me. It's my pleasure to be with you guys and to talk about epicardial PVCs and Brugada syndrome. I will present 2 cases. And I would like you guys to focus because I will go more in some questions and it would be nice if we can share the clinical decision on them. So the first case is a 45 years old male. Long history of paroxysmal atrial fibrillation and atrial tachycardia. He had failed ablation in Germany in 1988. At that time, his ejection fraction is 55%. In 1990, presented with history of heart failure, and the echo showed the ejection fraction now is dropping to 40%. And that time he was admitted, and the telemetry, he had been shown to have an atrial attack, run of atrial attack, atrial fib, and infrequent PVCs. And that time he treated with the ACE inhibitor, beta blocker. And then he disappeared. In 2007, admitted again with a congestive heart failure. And now his ejection fraction dropping more, 35 to 40%. He had an angiogram, which was normal, and someone started him cetalol, 80 milligram BID. That's the ECG in 2007, while he's taking the cetalol. And if you look at the ECG, they are sometimes sinus, there are some PACs, a short run of maybe a couple of PACs. That's his Holter in 2008, while he's in cetalol. You see the PVCs is only 1.5. And there are some short run in the report of AFib. That's the heart variation the whole day. That's some strips of his Holter, and clearly he go in short run of AFib. And there are some occasional PVCs. So he disappeared again, and again in 2009, and now admitted. His ejection fraction is dropping now to 25-30%. His treating physician that time he started him again in all the medication, carvedilol, carvacil, and also he started him in amio, 200 milligram TID for 10 days, and then BID for 10 days, and then once a day. Also he started him in anticoagulation. To prevent stroke. Discharged home with above medication, and he referred him to the my clinic. So when he came to the clinic, that is ECG now. The ECG, this is in 2009. He's in AMU. Now you see they are frequent PVCs, it's almost by Gemini. His ejection fraction, I think everyone will agree, this is low ejection fraction, maybe around 25-30%. LV is dilated. We did the Holter. Now the PVC is 38.4 burden. And the Holter does not show any AFib. If you look to his heart rate variation in the whole day, his heart rate is maximum go to 101. Now this is his Holter. You see they are frequent PVCs, short run of non-sustained. So the question is, this guy, when he was having AFib, an atrial attack, ejection fraction was 55%. Then in acetylol, there was no PVCs. Someone started him in amidrone. Now the PVCs is more frequent, and the ejection fraction is dropping. So the question is, what's most likely causing his dilated cardiomyopathy? Is it the AFib, atrial attack, inducing cardiomyopathy? Or is it PVCs inducing cardiomyopathy? Or is it maybe idiopathic dilated cardiomyopathy, and this is a result, the PVCs and the AFib is just a result of that. Or maybe both, or we don't know. I don't know how many will vote. Who will vote for, I will say, I don't know why I said, there are a lot of A more than B. So who will vote, and this is a PVCs induced cardiomyopathy? Okay, who will say AFib, tachycardia induced cardiomyopathy? Who will say maybe both? Who will say I don't know? I don't know, when I review his file, I thought, it could be a combination. It's maybe an atrial attack induced cardiomyopathy, it may be PVCs causing his cardiomyopathy. That time there was no cardiac MRI available in our center. It was in 2009. Ideally, should be the MRI. It may help to see if there are fibrosis or not. So it's really a dilemma. Which one is causing which, and is it the dilated cardiomyopathy is causing both? And then the question is, why does PVC's frequency increase after starting the AMU? So, as Dr. The previous lecturer say that AMU is suppressed, but sometimes does not suppress. And this guy, his PVCs before we start AMU is only 1.5. Now is almost 38%. Is this patient has sodium channelopathy, like Brugada syndrome? Is it secondary to progressive his dilated cardiomyopathy? Is the SVTs, atrial attack and AFib, was suppressing the PVC focus, or we don't know? Who will photo is a SVT, or his atrial attack, AFib was suppressing the PVCs? Or we don't know? And I think as we mentioned, so one of the side effects of the AMU is suppress it causes bradycardia, and these focuses sometimes it become more firing because the atrial attack and AFib suppress the focus. So the question is, what's the next step? Continue with the same medication, or do an EP study, try to ablate the atrial attack and AFib and PVCs, or tackle one of them, or just increase the beta blocker, or DC the AMU. For sake of time, I will put my thought. We decide it's better for him to go for an EP study and ablation for his PVCs and maybe his AFib. Anyway, the question is, where is PVCs coming from? Is it RVOT, is it LVOT, or is it aortic cusp, or epicardial? So I don't know if it's clear from there, but it looked like most likely epicardial. I will tell you why. Anyway, regarding there are a lot of logarithms. Will not go to localize where the PVC is coming. That's purely for electrophysiology. But they are a nice diagram which I use most of the time, where you try to see where the axis of your PVC morphology, what's matching in this ECG. And if you look to that patient ECG, it's suggestive it's coming from the LV summit. And if you look to the QRS in V2 and V3 in this patient, you will see the maximum deflection index is more than 0.55. And the maximum deflect index, we measure it from the beginning of the QRS to the peak of the R. And if the duration is more than 55% of the QRS duration, is very strongly suggestive this is coming from epicardial, which is in the case of this patient. And about 15% of the epicardial PVCs, usually it come a perivascular site of origin. So sometimes that help you can reach it through the coronary sinus, but also you need to check when you are ablating, sometimes could be close to some main arteries, coronary arteries. So back to the case. So the patient was sent abroad at that time for RF ablation, for atrial tag and AFib and PVCs, because that time there was no 3D mapping available in UAE, to be honest with you. So in overseas, they decide that it's an atrial tag AFib inducing cardiomyopathy. So they went and do the pulmonary vein ablation, advised the patient to continue taking amiodarone, and they wrote in their report that the PVC is secondary to cardiomyopathy, and they implant the CRTD in him. We will not go through why they implant CRTD. He may need an ICD, but his QR is very narrow. There are no indication for him to have an CRTD. Anyway, that's his ECG after the AFib ablation. Now he's in amio and he's still in sinus, but the PVC is still there. And still his ejection fraction is 25 to 30%. So what's the next step? We decide to take him to the lab and we ablate him at that time. And because in that patient, there are 3 strong predictors that this PVCs is causing his cardiomyopathy. One, PVC's burden is more than 20%. The 24% is what's in the literature, but I use cut point is 20. Is easier. The duration of the PVC, the QRS width is more than 150 milliseconds, and it's epicardial. All these 3 factors, when it's present together, is very strong that this patient, he may develop cardiomyopathy in the future. So in the literature, someone is asking why is it 20% or now in the guideline, European guideline is 10%. If you have a patient with the structural heart disease or cardiomyopathy and you have a PVC is 10% and more, they recommend this patient to be tackled with ablation. So that's the PVCs is in the lab. We went through the coronary side and the LV summit. We checked his coronaries, and in that area there was like almost 35 millisecond PQRS signal, and we deliver this is his during the ablation. You see when the RF started, in a few seconds the PVCs disappear. So post-ablation, the amiodarone was stopped. We increased his beta blocker, and our plan, if the patient have recurrent of AFib, we'll start him in cetalol. So that's 8 months later, post-ablation. The patient PVC is not seen in the ECGs, and the PVCs in the Holter is less than 0.1. That's his ejection fraction now. I think everyone will agree, no, maybe not completely normal, but it's almost around 50%. So this is second case. So 28 years old male with a history of recurrent feeling of palpitation, came to the emergency in 2002 complaining with the same issues, palpitation. While he's waiting in the emergency room, he arrested. They hooked him to the monitor, was ventricular fibrillation. They cardivert him and they start him in amio. And that was in the north of Emirates, in Iraq. So they transfer him to our hospital, recurrent ventricular fibrillation. They continue amiodarone. That time in 2, there was no electrophysiology service in the country. The patient was sent abroad, had an ICD in UK, and they advised him to discontinue the amio. In 2007, he presented with inappropriate shock because of fast AFib. He treated with IV amiodarone and started to have frequent PVCs, and now he started to have appropriate shock. He was admitted. That's the CCU telemetry, and if you looked at that, he go in AFib. Sometimes he go bradycardia, the device pacing him. Sometimes he should have a short run of VT, a non-sustained VT, sorry, and some PVCs. If you look at this monitor, also he had some PVCs, and that some PVCs very close to the T wave. And that's when he was in the CCU, he had the PVCs in the T wave, he went in ventricular fibrillation and shocked by the device. So this patient was settled down, discharged home, he had a Holter. Now it showed a frequent PVCs, 45%, and the ejection fraction dropped to 35%. He was sent abroad for ablation in the US. He had PVC ablation, endocardial and epicardial, and they stopped the amio, and his PVC is now less than 1%. He went again for pulmonary vein isolation also in US in 2009, and kept in metoprolol, and he was stable. In 2009, he came to the emergency room and developed ventricular fibrillation and VT storm. And he received like 5 to 6 appropriate shock. So IV amiodarone was started, and that's his ECG. Sorry. So what's the diagnosis? So if you look at the ECG, it's clearly they are Brugada type 1 ECG. Yes, they are a junction rhythm, type 1 Brugada. They are PVCs, and it's also some early liberalization in the inferior leads. So the patient was diagnosed to have Brugada syndrome, and amiodarone and metoprolol was stopped. IV isoproterenol infusion was started, and oral quinidine. We went and retrieved his file in the north of Emirates when he was presenting, that time with a palpitation. The one day before, he saw a cardiologist, and he found him to have an AFib, and he prescribed propafenone. And in 24 hours, he presented to the emergency room with a feeling more palpitation, and we think it was a Brugada which propafenone provoked the ventricular fibrillation. So 6 months later, the quinidine was stopped. He had a recurrent of AFib. Now he's still in quinidine and diltiazem for rate control. So the quinidine is class 1A antiarrhythmic, and is very effective treatment. Is almost 80% preventing the patient to have a shock from the ventricular fibrillation from the Brugada. I will skip this for time. The Epicardial RVOT ablation is an option. Have been a lot of publications since 2015 with a good result. Especially they use a flecainide infusion, and to confirm that they no more provoke type 1 ECG after ablation and during the lab. And before 5 years, it was class 2P, but if you look to the European guideline, now is a class 2A, catheter ablation for trigger PVCs and RVOT PVCs. The Bravo registry, which is just published in May 2023, this is about 150 patients had an ablation, and they have been doing very well, and with minimum recurrent of patient who had received ablation. And the mainly recurrent in the patient, which was 8 patients who have been still having Brugada type 1 after ablation. So the take-home message is PVC evaluation, but it's very important to take history and physical examination and 12-lead ECG, Holter ECG and echo. Cardiac MRI is useful in a selected patient. BVC Verdant is the most reliable BVC associated with the predicted of incident of heart failure. Beta blocker, calcium channel blocker, or catheter ablation are each reasonable first-line strategy to treat the BVCs, with a final decision driven by the specific patient characteristic and preference. The new BVCs or frequent BVCs, both starting antiarrhythmic medication, all the time think about channelopathy. Thank you.
Any question? Maybe one question.
Dr. Salem, thank you very much. For those cases whom presented with VT or VF, occasionally the ECG normal. If we exclude by echo other things, structural abnormality, we should exclude Brugada by provocative test or challenge test, putting the patient in CCU and give him class 1 type A antiarrhythmic drugs, either Rithmodan or quinidine. On that base, there are indications for ICD. As you know, and all of us know, there is no medical treatment for Brugada. The only treatment is ICD. But what are the indications for ICD? Or first of all, what provoked the changes? Myself may be a case of Brugada, but what precipitate or provoked VT or VF? It is said that fever, increased autonomic tone, tachycardia, and drug. A drug here, class 1, type A, that is one. Regarding the indication of ICD, sudden cardiac death in the patient, or second cardiac, I have the changes, but there is family history of sudden cardiac death, or appearance of the ECG changes on provocative test, syncope. All these are indication for Brugada. Well, as I told you, you know better than me. In many times, on occasion, the ECG normal, and other occasions may be positive changes. So we should have high index of suspicion for a Brugada in any case of VT or VF or sudden cardiac death.
No, I agree, and I think the most important when you start any patient antiarrhythmic, especially in young people or even the old, you need to get an ECG before you discharge them. Even if you see a patient in the emergency room with the AFib and you start them propofenone or flecainide or something, you need to bring them back or do an ECG before discharging them, 4 hours, 6 hours, if you are discharging him home, and bring him to your clinic sooner, 3 or 4 days, to check if there are any change in their ECG, because some patient you can figure it out. We have, like, just recently we admit one guy with the AFib, young guy, is in his early 40s. He came with AFib, and when we looked at the ECG, which was in our file 3 months back, it was type 1 Brugada. So this patient, you will not use an antiarrhythmic other than quinidine.
But we should emphasize to the audience, there is no medical therapy. Yet occasionally the patient refuses ICD and the doctor prescribes some sort of therapy, antiarrhythmia. This is wrong. There is no, I will repeat, there is no medical therapy. The only treatment, ICD.
Excuse me. I think there are other, it's not just ICD, you have ablation for Brugada. And you can, if it's not type 1, you can infuse Ajmaline in the EP lab and do ablation. So it's not just ICD at all.
And I think, see, the majority of the Brugada patient, in our registry, the majority of the Brugada patient, if they avoid the contraindicated medication, they are doing very well. The incident of ventricular fibrillation is very minimum. It's not exceeding like 1 to 2%. So the main treatment for these patients, if you discover them, they avoid these medication and how to control their temperature when they get fever, the children or the adult. So that's the main treatment for them. If the patient refuses ICD, quinidine is a treatment, have been used in some countries and with very good effect. Ablation now is coming up. I think will become an option for a patient who is refusing an ICD and refusing quinidine. It will be the option that you go for ablation and you have your end result. I think the end result will be that disappearance of type 1 Brugada during Ajmalin or flecainide test after ablation. If you have no more type 1, then I think, according to what current literatures, is very strongly that you're almost maybe cured from the Brugada syndrome.
And I think you can always put an ICD, but you have to think about the next step. Like if he has like many shocks or shock storm, so you have always to put ablation in front of your eyes.
It's currently the ablation is the third option. Second option. The first option, the quinidine, is very cheap. There are a lot of side effects from it. Many patients, they don't tolerate it, and mainly diarrhea. But if the patient tolerates it, is a good option until we know the strong. I mean, we have more evidence about the ablation and it becoming the guideline.
Dr. Raed.
Thank you for the nice talks. I guess we need to take advantage of the electricity guys all in the same room and ask any question, right? So my question is about atrial fibrillation, incidental findings on Holter. That's very transient. The new data now coming on board saying that it's not as risky as it was or as we thought before. Is that what you guys practice? To ignore it?
It depends on the duration and the load of atrial fibrillation.
We are talking about
like
few seconds.
Hours or seconds or minutes.
Seconds. The guideline is very clear. You cannot call it an AFib unless it's sustained more than 5 minutes in the device, which is, I mean, if you look at the device literature, any patient with 5 minutes, or I think 5 or 6 minutes, something like that, 5 minutes, then you assess the CHAD score. If the CHAD score, you advise for anticoagulation. What's the evidence about the Holter? Okay, we apply the 5 minutes, to be honestly, generally. And if you see like 10 second, 15 second of what's suggestive of AFib, okay, we don't take an action on it, to be honest with you. I don't know what's about the others. I don't know.
So I guess, Isa, my question is, if you find these incidental findings less than 5 minutes on a Holter of 24 hours, is that an indication to go for a long-term Holter or loop monitor just to document that? Because that patient you might not have caught the longer run that might have another day or happen another day.
Is the patient symptomatic, Raed?
No.
Does he have symptoms?
My personal opinion, it all depends on why you put the Holter. So if the patient, for example, let's not forget that 1 out of 3 patients who have a stroke of unknown etiology is because of atrial fibrillation. And this is the reason why we generally put those long-term Holters to see if you have any AFibs. Personally, from my experience, and this might be so, if I see a lot of atrial runs in somebody where I'm putting this Holter for potential stroke, who's had a stroke of unknown etiology, I do anticoagulate. But if I get a 40-year-old female with CHADS VASC of 0, and well, she'd be a CHADS VASC of 1 because she's female, and we find this atrial run in there, I just follow it. And you also want to look at the timing of this. If it happens at night, so then a sleep study is something very important. That's my personal thing.
Yeah. And sometimes some our colleagues, they interpret some Holter not rightly. Sometimes the PACs when it comes, they see it irregular, and they call it AFib. And we see it, to be honest with some, we have some referral like this, and they commit them in anticoagulation, and it's not truly AFib.
يعني asymptomatic atrial fibrillation المشكلة two things. أول شغلة risk of stroke. هذا this is very important in patients with high CHAD score should be on anticoagulation. Second thing is a marker that patients need to go to aggressive lifestyle modifications, because atrial fibrillation is an indication that lifestyle is not good. Indication of other comorbidities that goes around, like uncontrolled diabetes, uncontrolled hypertension, thyroid dysfunction, whatever. So chronic diseases like cancer can cause AFib as well. So this is a marker that you need to work on your patient. But from the beginning, the risk score or risk CHAD VASC score is very important to be assessed in these patients.
Dr. Salem, thanks very much for this interesting presentation. We have to give time for the next session, so thank you everybody.